Dr. Liu, please.
Okay. Good morning, everyone. It's my honor to be invited here. Today, I would like to explore an interesting question. Do atropine eye drops cause progression of exotropia in children? Intermittent XT or IXT and myopia commonly coexist. The prevalence of IXT is approximately 1% in the United States and about 4% in East Asia. Meanwhile, the prevalence of childhood myopia continues to rise and had reached epidemic levels in certain East Asian countries, including Taiwan. The coexistence of these two conditions are not merely due to their high prevalence. Population-based studies have suggested that IXT and myopia may serve as risk factors for each other. In other words, they are not only frequently occur together, but also they have mutual influence on their development. For children with IST, the treatment options, there are several treatment options available. For those who have good control in their exotropia, observation is a reasonable approach, as deterioration in 1 to 2 years is uncommon. Other treatment choices including part-time patching and over-minor spectacle, which aim to improve XT control. However, their effects are often transient. When it comes to myopia control, there are now multiple treatment options available. For children with both IXT and myopia, spectacles or contact lenses are beneficial as they correct refractive error, provide clear vision, and help in children's XT control. But what about atropine? The use of atropine may have conflicting effects in XT. On one hand, atropine reduces accommodative amplitude and requires great effort in accommodation, which in turn enhances accommodative convergence. This may potentially improve XT condition. On the other hand, atropine induces blurred images or photophobia, which may disrupt functional convergence and may potentially worsen IXT. So, what is the real clinical effect? Is it good, bad, or actually no effect on IXT in children? A randomized clinical trial conducted in China, published last year, provide a clear answer to this question. The study compared 0.01% atropine and a placebo in children with XT and myopia. Their findings demonstrated a 1-year efficacy in atropine for myopia control. The study also demonstrated that the deviation magnitude and the XT control score remains stable in children using atropine compared to those receiving a placebo. They even demonstrated an improvement in near deviation magnitude in children treated with atropine. So, the key message is 0.01% atropine eye drops are effective and safe in slowing myopia progression without interfering with exotropia conditions. However, this RCT was limited to children with good or fair XT control at baseline, and they use the low-dose atropine, and they have only a 1-year follow-up period. So, how about higher concentration and longer use of atropine, which is the real-world setting, especially in certain East Asian countries like Taiwan? In Taiwan, higher dose and longer duration of atropine indeed is commonly used in children for myopia control. In fact, 67% of Taiwanese school children with myopia have been prescribed atropine eye drops, and with a median duration of about 1 year. So this practice raised the concern about the effect of long-term atropine use on XT in children. So therefore, I conducted a long-term retrospective clinical observation at our hospital. We collect data of IXT children with IXT, and who have been followed up for at least 1 year before and 2 years after 0.1% atropine use. And the XT condition was compared before and after the atropine use. This study is still ongoing, and I'm here to share the preliminary result of my cases. Okay, for children who did not undergo strabismus surgery, implying that they have fair or stable XT control, I found no significant difference in XT deviation between before and after atropine use. This is the graph of one of the cases. The vertical line represented the time point when the atropine treatment was started. And as you can see, the XT deviation remains stable before and after the atropine use. However, for children who had undergone strabismus surgery, implying that they have poor or unacceptable XT control, I found 2 of 4 cases showed XT deterioration after atropine use. As you can see from this graph, this particular case remained stable after the strabismus surgery. However, it showed deterioration after the initiation of atropine treatment. So in summary, for children with stable and fair XT control, atropine eye drops does not cause XT progression, even in higher dose and longer duration. And this is based according to my limited clinical observation. But however, for children who require strabismus surgery, high-dose atropine eye drops use may be associated with XT progression and should be used with caution. It is important to note that this statement was based on my very limited clinical observation, and the study is still ongoing. Thank you for your attention.
Thank you, Dr. Liu. We allow for one question, if there is any. Yep. Miho, please.
With the orthokeratology, the use of orthotic contact lenses.
No, I haven't data.
In the Asian countries, the use of atropine availability is okay. But the other modality of this medical treatment of myopia is the orthotic contact lenses.
Yeah.
They are put to the children and they cause during night corneal reshopping and the myopia disappears. And they are also supposed to regress the myopia by about 40%. But the thing is that it's okay in that well-developed countries like USA, UK, because the cost is high, its use, its complication can be managed there. But in India and other countries, as you rightly said, the use of atropine is the best outstanding modality of the treatment.
Yeah. Thank you.
Thank you.
Please.
Thank you for the second question. In our study, we noticed the patient who had anisometropia is more likely to develop to acquired esotropia, and also the intermittent exotropia patients develop anisometropia so strongly. Have you ever checked the anisometropia after atropine use?
Yeah, this is a good question. So in my clinical observation, we observe a large amount of anisomyopia in children who treated with atropine. So I'm not very sure about the deterioration, the XT deterioration. Is it merely caused by atropine use, or is it caused by their development of anisomyopia? So this analysis will be conducted in our study, and we will do a stratification or adjustment for their myopia progression and the anisomyopia. So maybe we'll give you the clear answer after study. Yeah.
If a child has intermittent exotropia and not much of myopia, but he's not wearing his glasses, not doing exercises which he's told to do, what will happen to the intermittent exotropia? Will it progress, or will it remain stable?
Some of them, most of them, if they are presented with to you and it shows a low XT control, a higher control score, means that they have a good control for their XT. Studies have shown that if they have baseline good control of their XT,
There is good control.
it is uncommon for them to progress in 1 to 2 or 3 years. So you can only just follow up.
Just
Yeah.
observe.
Yes.
Oh, thank you.
Thank you so much,